Good morning, everyone. My name is Gerda, and I'm the General Manager for the National Office at the Muscular Dystrophy Foundation of South Africa. And I just wanted to welcome all of you to the webinar today and then introduce our very special speaker, Dr. Anri. Anri is a board member of the MDFSA, and she's also a qualified physiotherapist with a passion for neuromuscular disorders, and in particular, cough augmentation and inspiratory muscle training. So that sounds like a whole mouthful, and I'm sure Anri is going to tell us a little bit more about that. So welcome to everyone. Welcome, Anri, and we hand over to you. Thank you.
Good morning, and thank you so much for the gracious introduction, Gerda. It's much appreciated. Good morning to each and every one of you. Thank you for joining us, and thank you for sacrificing your Saturday morning. I am truly going to try my utmost human best to keep you interested, entertained, and hopefully engaged. And I hope that we'll be able to share a few ideas today. And thank you so much also to the Muscular Dystrophy Foundation for inviting me for this talk today. I'm just going to switch off my video for now because I do have quite a number of diagrams and pictures in my presentation. If I do need to explain something or demonstrate, then I will do so. Right, so let's get going. This is one of my favorite topics, like Gerda said, and I will just quickly give you a brief overview of myself, and yeah, then we get going. So, as you've probably seen, my surname is Himan, and it works really well if you use it in English. I always tease and tell my colleagues and my students that if I do make a mistake, my humble apologies, I'm only human. So, but my background is basically I'm a Pretoria born and bred girl, Jacaranda City, and I qualified at the University of Pretoria. I've been a physiotherapist for approximately 20 years, of which 14 of those years I've been in academia and a permanent lecturer, and having lots of fun and meeting amazing people along the way. And my journey with patients with neuromuscular diseases started approximately 10 years ago. And I must say, I have been so privileged to be able to meet amazing real life heroes, and that is each and every person that is actually having a neuromuscular disorder and living and fighting this every single day. I salute all of you. And also standing on the shoulder of giants, being able to be involved with the Treat NMD, people like Prof. Volker Straub, Muscular Dystrophy Foundation of South Africa, of course. And as you can see, we have 2 border collies, and I tend to dress the one up in red, usually for Muscular Dystrophy Awareness Day, as you can see there at the bottom corner of the slide. And I also just want to give a disclaimer and say I love Winnie the Pooh. I will blame my mother for that because she used to read that for me when I was little, and I still haven't outgrown that as yet. So I did my community service here in KwaZulu-Natal at Potchefstroom Hospital. Thereafter I came back to Pretoria, and as I say, I've been involved with NMD for quite a number of years. And my passion is really, I think even with my research, I've realized that our members and our patients and our families, and even I want to say my fellow colleagues, we do not actually know enough about respiratory management or actually what we can do, and there is so much that can be done. So I hope that today, this is just going to be a small little taste. Unfortunately, we can't cover everything in one morning, but I hope that I'll be able to open your minds and just maybe make you aware of a few things that you should ask your physiotherapist and your pulmonologist and your doctors, and that we can get this conversation going, because it's really so important. We have to change the world one patient at a time. So yes, so at the moment, and I'm also very grateful, I am at the University of Pretoria currently, and I'm very happy to be here where there is no load shedding. That's the advantage of working alongside a hospital. But I just want to, at this stage, remind all of us that breathing is so important. Eric said previously that you can go without food and water for some time, but we can't go without breathing. So I would like all of you to please just quickly put your one hand on your tummy, on your abdomen, and the other hand on the top of your chest. And at this stage, I want you to please take in a nice deep breath in through the nose and out through the mouth. And I want you to become aware of your breathing. And the correct way of actually doing this is to push out as you take a deep breath in, your diaphragm, your main breathing muscle per se. It's moving downwards, so it actually pushes out your tummy. So your tummy is supposed to push out as you take a deep breath in, and then as you breathe out, the tummy goes back again. So I want all of us to just quickly take 5 seconds and just do a few nice deep breaths. Let's do that. So hands on the tummy here, on the top of the chest. So nice deep breath in and breathe out. Okay, and don't pull up the shoulders, please. Relax the shoulders and deep breath in and out. Well done. It's looking good. And we're going to do it one more time. Deep breath in and out. Good job, everyone. Thank you so much for that. I hope you are now well oxygenated also, and we can continue. So now we have been reminded once more how important breathing is. Okay, so I would like to know a little bit, please, about your expectations. With my interaction with my patients, with a lot of the members from MDFSA, members on the committee, as well as research and literature, we found that people with neuromuscular diseases said their expectations from us as healthcare professionals is to help them to improve their survival, improve their independence. They want to be as independent as possible, improve their functional ability, and to slow down the disease progression, because we know that at this stage we do not have a cure for NMD. There are a lot of very smart colleagues that are working on the research, and it's really a very exciting time in the world of NMD and what's happening with genetic manipulation and all of that. But at the moment, as it stands, we do not have a cure, but there are other things we can do. We want to improve health-related quality of life. We want to make sure that you can live to your utmost potential and have the fullest life that you can have. And that's actually a lesson for all of us, even myself included. We have to live to the full. So what I'm going to share with you today is also hopefully going to remind us of what can be done in order for us to improve health-related quality of life. And interesting also what came from the patients was that they all would like to have access to multidisciplinary care. Unfortunately, this is a reality of our country, that not all of our patients do have access to pulmonologists, cardiologists, physiotherapists, occupational therapists, speech therapists, dietitians, etc. And this is also something that I think, well, the society and everybody in our country, we're really working towards that to try and see how we can take hands and make this a reality. So I'm going to ask, please, don't feel shy. You're either welcome to unmute your mic or you can type in the chat box for me. I would just like to know from your side, what are your expectations? What do you hope for us as healthcare professionals to help you with, or your family member, whoever is affected by NMD? What can the society do for you? It just gives us a good idea so that all of us can pull in the same direction. I've already given the disclaimer to say that I love Winnie the Pooh. So I just want to say, if you see on a slide today that there's a Winnie the Pooh somewhere, like the one here at the bottom of the slide, it means that I will ask you for your input, or there will be some other interaction, because I really want us to engage. It's not going to be a one-way conversation. I do not know everything, and I would love to hear from you and to learn from you. So please go ahead. Gerda's going to help me to keep an eye on the chat and just tell us your thoughts, please. So let us know, what are you expecting from us as healthcare professionals, as MDFSA? What can we do for you? You're welcome to either unmute, or you can just type in the chat box, and then Gerda will let me know what your thoughts are. Seems like everybody's shy this morning, or they haven't had their coffee yet. Yes, Gerda.
Sorry, Anri. Maybe I can just add a little something. From MDF side, we definitely would like our medical professionals to sort of specialize in muscular dystrophy. It happens so often that people go to a doctor, or in an emergency, they go to a hospital, and whoever the admission doctor is hardly knows anything about muscular dystrophy. So that is we feel, one of the big challenges in South Africa.
I do agree with you, Gerda. That's been my experience as well, and I think it comes down to, again, knowledge is power. And I think this meeting today is hopefully also one step in the right direction, because I want to say, if each one of us that are present today can just share information with one more person, we're going to have a great impact on our community. But I agree, and I know I'm only one person, but I am from my side. I had 2 weeks ago, I had a presentation with my colleagues at Steve Biko Academic Hospital, specifically also about neuromuscular disorders, and they asked me to come back for a few follow-up sessions. So I think once more, if all of us start working together and we pull together as a team, this is possible. But thank you so much for mentioning that. That is definitely one of the components that I've identified with my research, that we need to empower our healthcare team as well. Thank you, Gerda. Are there any other comments that anybody would like to make? Please don't feel shy. This is a safe space and you're welcome to speak your heart. Okay, but I have noted your concern, Gerda, and I'm definitely, I've got a pen and a paper here. I'm being a real student. We will consider this with our future projects, and I know when we have our committee meetings, this is one of the, I think, items that always is on the agenda. How can we actually expand knowledge and get the message out there? So in the absence of any further comments, I'm just going to move along, and then once more is another Winnie the Pooh, and I would like to hear your thoughts if you agree or disagree. Now, previously with my discussions with the limb-girdle muscular dystrophy group, as well as with what has been published in literature and my other patients, 4 main components actually stood out, where patients said that their concerns were mainly their respiratory functions, so their lung functions. They experienced pain, fatigue, and then motor function. But some of our members have said they also think that it depends on the area that you're in, what type of support you have, when your diagnosis was made, what your comorbidities, what your other conditions are, but also your age, and in what stage of the disease or the condition you might be. Because if, for instance, at the moment, you're still ambulant, you're still walking, then mobility and motor function and independence is very important. As soon as we start using a wheelchair, then I think pain and fatigue comes into play, and then also respiratory function. So as the disease progresses, lung function and heart function becomes more of a priority. So I would just like to hear if anybody would like to share, and Gerda, you're also welcome to share. What is your main concern? What do you experience as something that is at this stage where you're at in your condition and your age? And Gerda, you don't have to give your age, not at all. As females, we do not grow old and we don't tell our age and we don't tell our weight. But what are the things that are currently concerned to you? What's sort of the primary problem or challenge that you face at this stage? Please either unmute yourselves and let us know, or you're welcome to type in the chat box.
Okay, it seems like I'm first every time. I think everyone I think everyone knows that I'm also affected by muscular dystrophy. I've got facioscapulohumeral muscular dystrophy. And I'm now in that in-between stage, you know, that I can still walk, but I can't access all the places while I'm walking, you know, so I can't go somewhere and then have to sit. Because if I sit, I can't get back up. So I'm in that limbo, that in-between place between using a wheelchair and not using a wheelchair. You know, so when is a good time to actually start using a wheelchair? Because my opinion is if you don't use it, you lose it. So I want to stay on my feet as long as possible.
And I think a lot of the members will share your opinion there. We want to be ambulant for as long as possible, and obviously try and maintain our independence for as long as possible as well. And I definitely agree with that. Obviously, yes, there's that balance, because if you don't use it, you lose it. But then on the other hand, also, especially with your dystrophinopathies, there's also the risk that we don't want to overexert ourselves. So Gerda, you're not allowed to go and train for the comrades. That's basically what I'm saying. So yes, to a limited extent, it's good to stay active and to do what you can, but to also not, on the other hand, push yourselves too hard, because there is a risk within the muscles that have a lack of or limited dystrophin, that when we do exercise, there's this protective mechanism. It's called the nitric oxide release mechanism, that might be a bit faulty when it comes to patients with dystrophinopathies, and therefore the muscles are not as well protected as with people without NMD, and then overexerting and doing exercises at a major and a very high level and intensity level might actually cause damage to the muscles. But as you say, you're walking, you're still ambulant, you're doing things within your house, that is great. Try and keep that up, because there's also a very strong association and a link between mobility, so the fact that you're still mobile, and your lung function. So the more mobile you are, the better your lung function is. It's usually once we start using a wheelchair more permanently when lung function then also starts regressing. So thank you for mentioning that, Gerda. I think that is really important, and it's also interesting to also think about that, because maybe some of our other members that are online here today are also in a transition phase, and this is now when we have to start thinking about what type of wheelchair we might require, monitoring our lung function a bit more often. So this is truly important. Thank you so much for raising that. Any other comments or questions?
There was a comment from George, and he says, as I'm getting older, I'm struggling more to cough, and he has problems when he has phlegm on his chest. And I saw he had his hand up. So it's George, and then Sari, and then Hanifa that had their hands up.
Thank you so much.
It is...
Sorry, go ahead.
Okay, it's sorry. What I noticed, because with especially with awareness, because we run the whole September awareness, our country have an extremely shortfall for people, disabled people. Doesn't matter what is your problem, even if you walk difficult or whatever is. I think we really have, from shopping centers to doctors, even places where you will think they, where they do have things for disability, they don't look after the disabled people. They're not disabled friendly.
I do agree with you, sorry, because that's something that I've had a discussion with my students about. A lot of our children at the special schools with CP, and then they're using wheelchairs. They have difficulty going with their mothers or their parents or someone to the shopping mall, because there are no ramps available. If they need to go to the bathroom, the space is not big enough for them to maneuver with their wheelchair. So I agree that this is really something that we all of us have to work on. But I think if each one of us add our voice, hopefully somewhere along the line, somebody's going to start listening.
And I think also I'm very bad. My husband also, when we get at shopping malls and people parked on disabled parking, I lose myself. And they're not disabled. I'm very, very bad with that, because I take the people on, and sometimes I force the people to move the vehicles. They freak out. I've got the other day, I was stopped at the parking place where disabled parking. I was standing there, and a guy want to pull in there, and I look at him and I say, "You're not disabled. I will not move." I stand on it, and I think we, as normal people that don't have any disabled function things, we have to stand up as public, to stand up for people that's disabled.
I second that, and I want to say amen, sister. Absolutely.
Yes, and I will keep on fighting.
Please do so, because I would sometimes make the comment like, "Wow, it's a miracle, he can walk." Then
yes.
Hopefully the penny drops. But I'm also thinking, with reference to that, Gerda, maybe we should consider as MDFSA to print stickers or something that we can put on the windscreens, to say, you're not disabled, or this is a disabled parking, please move your car so that someone with a disability can actually use it.
That's an excellent idea.
Can't we spread? We can spread the stickers also to other people.
I agree. I think this is, wow, you see already we've got beautiful ideas coming forth here today to make a difference in our communities. Wonderful. And then I think with regards to George also had a comment about having difficulty in coughing. So I'm so happy that you're here, George, because this is going to be part of my presentation today. But you also had your hand up. Would you like to add a comment or elaborate on your comment in the chat box?
No, not really. It was purely that I wasn't sure that you're going to see the comment. I'm trying to stay as mobile as possible still. I'm 64. I don't have a problem sharing my age. I suppose because I'm male. But I try to maintain mobility. I still play golf if I can. Obviously, I don't walk. I use a golf cart most of the time. Just walk onto the tee box and off, and onto the green and off. But I try to stay mobile, and I'm finding that that helps with the lung function. Where I do have a problem is on my left knee. The typical knee hyperextension where I get inflammation in the knee and then I struggle walking. And I've got to purposely try and walk as slow as possible. Otherwise, my knee starts acting up. But in terms of, those things you can manage. And even though it is a pain in the butt, you can live within the confines. But where I do, and the last 2-3 weeks I've had flu, and then I can feel the respiratory function starting, the problem starting to come through, because I'm really struggling to get the phlegm out of my chest.
Okay, and that's also, so besides, depending on which stage of the disease you're at, I think it's also then if we should have any respiratory tract infections, or now where we have a change in seasons. So thank you, that's a very good comment. And I'm definitely going to touch on coughing and what we can do to assist you to get that phlegm out of your chest. Thank you so much, George. I think there was another hand that was up, or someone else that also wanted to make a comment.
Yeah, it was Hanifa's hand that was up.
Hi. I currently have a son, 20-year-old, who has Duchenne's muscular dystrophy. We have a bit of a challenge at the moment where for the past year and a half he's been using his wheelchair because he has a dislocated hip.
I know.
So the dislocated hip is, not allowing him to be mobile, and that is why he's using his wheelchair most of the time. We would like to know how we can make it easier for him, like getting out of the wheelchair and onto his bed. What type of a bed should we use? And also when it comes to going, to the bathroom, using the toilet and so on, because that shifting from the wheelchair onto the toilet or to the bed is a challenge where he needs to be assisted.
I hear you, and obviously also don't want to cause additional pain and discomfort. I'm not, unfortunately, won't be able to touch today, maybe necessarily on the transfers or other mobility aids. But I think maybe if you don't mind to contact Gerda during the course of the week, she'll be able to put you in touch with. I'm sure Chris and Sally might be able to help, because there are. I mean, you can get toilet seat extenders, those ones that we usually use for patients with hip replacements. That'll just make life much easier. Because I can imagine this currently is quite a physical burden on you as well, because you now have to do the transfers. And we don't want mommy hurting her back either. So as I say, unfortunately, that's not within the scope of today's presentation. But definitely, I think, Gerda, sorry, maybe we can make a note then somewhere for in the near future to have something similar, or maybe address some of these mobility or transfer problems that people might experience. But as I say, for now, if you don't mind, just contacting Gerda, and then I'm sure we will be able to assist you, because this is something that has to be addressed as soon as possible.
Okay, thank you so much.
You're welcome. Thank you so
I'll
much
make
for
a
your
note.
comment. Bye, Dan.
And
Thank
then
you.
Giselle or Gazelle also has a hand up.
Wonderful. Now everybody's speaking. I like it. Please go ahead, Gazelle. You're welcome to give us your opinion as well.
Hi, can you hear me?
Yes, thank you.
Okay. My question is, I've been struggling with my medical aid. I'm on a medical aid, full med. They do have funds where they help you with disability items as well. They gave me a bath chair, which is approximately at its highest 25 centimeters to 30 centimeters high. And it's basically just like a bench. According to them, it's the cheapest one they've got, and it was like 600 rand. That was deducted from the medical aid. I'm currently looking for my own one, because like the medical aid, they don't, and in my opinion, I don't think the people that design the disability items aren't disabled, so they don't think how we gonna be able to be easier for us to use this stuff. Like the other person said, It's difficult to find the right stuff to use at home.
Yes, yes. And like you said, I think the challenge is the funding and the resources, because I know Gerda and everybody at MBFSA have been extremely hard at work to also get in and have meetings with our medical suppliers and medical insurance, medical aids, so that we can, again, it's once more about knowledge, because they don't understand the condition and they don't understand what it entails and what will be required. So this also comes down to, I think, all of us pulling together and maybe start compiling, petitions to say that this is not on, and this is not, it's unacceptable to us and to people with disabilities and to patients with NMD. And I'm very happy to add my signature to that, and even a small motivation with regarding the respiratory devices and support that will also be required, especially once we start using wheelchairs. So I think that's also something that we should maybe get going and once more reiterate. But I do agree with you, that is one of the main aspects that some of my patients have also mentioned, is they struggle with the medical aids and to get support for what they need. So thank you for mentioning that. I'm so sorry, I wish I could assist you directly at this stage, but just maybe it might be a little bit of a consolation to know that there are quite a number of people working on this as we speak. So, but once more, let's all work together, let's get those signatures in, and let's see if we can make a difference. Thank you so much for your comment. Anybody else that would like to share? All right, so I will give you a chance again to speak a bit later, but thank you for making your voice heard. This is really, it's great. I hate speaking into this great abyss and talking to myself. I know us as females tend to do that, but it's really much nicer if you talk back to me. Thank you for all your valuable comments. So this slide, and I would like all of us to just maybe think a little bit or consider, because with most of our neuromuscular diseases, we do have muscle weakness in some other area of the trunk, be it in the shoulder girdle, be it over the pelvis area. Most of the times the arms and the legs are also affected. But if we think, if I've got a picture here by Anri, it's sort of like a classic, everybody always refers to it. But for instance, A is a depiction of Duchenne or Becker muscular dystrophy, and the muscle weakness and the wasting or the atrophy that we see around the neck and the shoulder girdle, the arms, around the pelvis, as well as the lower limbs. And then, for instance, C is your limb girdle muscular dystrophy. But if we look at this, I think all of us can appreciate that there is trunk involvement. So the muscles of the trunk are going to be affected. So besides the fact that mobility becomes a problem, our muscles in between the ribs and our breathing muscles and our shoulder girdle muscles will most likely also be affected, and that is going to affect our breathing. So I just want, you don't have to comment at this stage, but I just want all of us to sort of reflect upon that a little bit. And that is also for us as healthcare professionals why making a diagnosis is so important. Because if we know the type of NMD, it helps us to actually plan, know about the prognosis and plan for future treatment and interventions. And also then, if new therapies become available, if you have your diagnosis, then you will qualify for certain therapies once we can get through the red tape and bring them from overseas to South Africa, of course. But so for us, early diagnosis leads to early intervention, leads to improved outcome for patients. And that's why we really, again, once more want to create awareness. And this is what this talk is also about, awareness about respiratory function, but also for us to be able to make the diagnosis earlier. I know some of my colleagues at Newcastle University in the UK, they've done some research and they found that the average age of boys that they've then assessed were diagnosed at about 4.5 years of age. And I know here in our country, it happens much later, which is really truly sad, because once more, the sooner we can start with intervention with your glucocorticosteroids, the outcome's going to be much better. So I just want you to think a little bit about maybe when your diagnosis was made, your specific type of NMD, and then also in your own experience, just think of what you've noted about maybe your shoulder girdle. I mean, George says that he's still playing golf. Hats off to you. So, I mean, I don't have NMD and I can't play golf, so well done. But it's also for us to think, how can this now influence, and how is this condition going to influence every aspect of our life, not only the mobility part. This is a follow-up.
Sorry, Anri.
Yes, Gerda.
Sorry, Anri.
No problem.
There's a question that someone from, it's actually a board member, Raj, posted on behalf of a parent.
Mhm.
And he wants to know, why is Duchenne more progressive than the other dystrophies?
Okay, so thank you so much for this question. It's a very interesting question, and I won't go into too much detail. But the bottom line is we talk about, and as I've mentioned here, interestingly enough on this slide, about phenotype. But phenotype basically refers to the clinical presentation, so how the patient presents, and then genotype refers to the genetic abnormality. So Duchenne muscular dystrophy is more progressive, for instance, as compared to limb-girdle muscular dystrophy. And it's because of the genetic mutation, and it's because of what happens within the muscle itself. So for instance, even if we compare Duchenne versus Becker muscular dystrophy, in Duchenne muscular dystrophy, they usually have a lack of dystrophin. So the protein that's supposed to stabilize your muscle membrane to make sure that it doesn't get any damage while exercising, while contracting and relaxing, that protein is absent. It's not there. While with Becker muscular dystrophy, you do have a little bit of dystrophin. So it might not be the normal amounts that we actually require in people without dystrophinopathies, but there are some molecules and they do have some proteins. And that is why, for instance, if you now compare Duchenne with Becker, that those with Becker can walk for longer, they're not as severely affected. So their phenotype looks different because of what's actually happening within that muscle. So it depends on the type of NMD. Even if you think of spinal muscular atrophy, there's a lack of the problem there is with the SMN1 and 2 proteins. Now, most of the times your patients with SMA do not have SMN1 protein. And this protein is usually found within the spinal cord, and that's what leads to the muscle weakness. But the more copies of the SMN2 protein that they do have, the better the patients will be doing. So you might have a patient with SMA and another one with the same type of SMA, for instance, but the one is doing a little bit better than the other. And part of the reason could be because of the number of copies of proteins that they have. So, and also what sometimes has an influence is the comorbidities of the other conditions. So for instance, if a patient has diabetes or asthma, as I've mentioned here as well, for instance, or high blood pressure, those conditions can also have an effect and then make the regression actually worse. And for instance, let them lose ambulation earlier or have more complications with their cardiac, with their heart function or with their lungs. So it basically boils down to the abnormality of the genetic mutation, which then leads to a certain clinical presentation, because the pathology can either be, when it comes to NMD, can either be in the muscle, in the nerve, or in the spinal cord, and then it depends on actually how severe that is, how many proteins do we have, what is the expression, and that is why we actually have a spectrum. So even when I'm going to be presenting about the treatment later on, I will say that this is based on individual assessment and you have to consult. We can't just use an umbrella intervention and everybody uses the same thing, because all of us are different. If you look at your thumb, all of us, we do have our fingerprints, we are individuals. So an individualized treatment plan is also going to be what we need for each and every patient. So I hope that answers the question without going into too much detail into the genetics. Okay, any other comments or questions? You're welcome. Anything else, Gerda? Any messages in the chat box for me?
No, nothing further.
Okay, thank you so much. So thank you so much also for the interaction and the communication and the suggestions, and even sometimes we just need a platform where we can make our voices heard, because it sometimes feels, well, to me, and I don't have NMD, but I mean, like we're running up against a wall and we're hitting a ceiling the whole time. And it's sometimes it's good to know that there are people sharing the same passions and we are actually experiencing the same challenges. But again, once more, as a team, we can get more done. And I think you have now again re-energized and motivated me to work even harder so that we can change a lot of these things that you have mentioned today. So just to now again come back to, I've added this little chest that's moving, the breathing, just to remind us and just to think a little bit more about, excuse me, the connection and the association of weakness in the trunk muscles and then how it might affect our breathing muscles. Because your diaphragm, your main breathing muscle, I don't know if any of you knew, but the diaphragm is our primary breathing muscle, but it's also a stability muscle. It helps to stabilize your trunk, it helps to stabilize the lower back. So it actually has a dual function. So now you can imagine, and again, it's a muscle. So if we have a progressive muscle weakness developing, then the diaphragm is also going to be affected. Your intercostal muscles, for instance, are also your breathing muscles. They also help to expand the chest. And if they also become progressively weak, besides the fact that your breathing is going to be affected, they also have a stabilizing function for the chest and the trunk. So I think we sometimes forget that there is a link here. And interestingly enough, hot off the press, it hasn't been published as yet, but my colleagues in the UK, again at Newcastle University, performed a study where they looked at the association between lung volume, so forced vital capacity, and upper limb function. And they did find, statistically significantly so, that there was an association between the upper limb function as well as the lung functions. So that's also why I want to make you aware that if your shoulder girdle or your upper limb function starts to regress, then just keep in mind that this might be an indication that your lung function is also regressing. So if you haven't then been for a pulmonary function test recently, please go and see your pulmonologist. So my message today is that respiratory, our lung, and our cardiac or heart function should be monitored, please. And the frequency, how often we should do it, is most likely going to depend on your level of ambulation. So if you're still mobile and you're walking around, then you should probably have this done once a year. This is what the clinical practice guidelines tell us. And then once you start using your wheelchair, more permanently so, then you should actually have your heart and your lung functions monitored twice a year. And then they also say we have to consider facts like age. So George, you are doing really, really well. And thank you for sharing your age, but I think that is amazing to still be so active. And there are a lot of other people younger than you that can't do as much. And then disease duration. So how far are you along with your regression? What is the severity of your condition? For instance, like we also had the previous question about the Duchenne versus the Becker. Obesity or a high BMI is a problem because if our midsection is a little bit too large, that's also going to cause compression on your diaphragm, further compression besides what you already have because of the underlying respiratory muscle weakness, and then that will also impede your breathing. So it's really important for us to try and maintain a good healthy weight. Eat your vegetables and your carrots and your celery sticks, and if needed, please go and see the dietitian. And then, of course, if there are any other underlying lung problems, such as, for instance, asthma, then this will also have an influence, a greater influence on your lung functions. And then even though you might still be ambulant or walking, then you might want to go and do pulmonary function testing twice a year, for instance, if you now have asthma, because the risk is just much higher. So this was just a small little reminder that there definitely is a link. I'll keep on referring back to this fact as well. Now, this is quite a busy picture, but they say that a picture speaks 1,000 words, and I've collated this in collaboration with a graphic designer, because I can't draw that well, to actually just present the story of neuromuscular diseases. Because of the respiratory muscle weakness, which now then progresses, so the breathing muscles become weaker, we have a few problems that might arise. And first of all, low lung volumes. Because if you think about it, previously when we took a nice deep breath, maybe once your muscles now become weaker, it might become more difficult for you to take a deep breath. And some of you might have actually noticed that. So once the lung volumes become lower, this is now what they test at that clinic visit, or when you go and see the doctor and they ask you to blow through this mouthpiece and device, and they tell you you've got 80%. So that is usually 80% of predicted value, or 60% of predicted value of the lung volumes that you should have for your sex, for your age, for your disease progression. So this just helps us to monitor these lung volumes. So we look at lung volumes like forced vital capacity, and then flows, for instance, forced expiratory volume in 1 second. So that is what the doctor and the pulmonologist is monitoring. Because if you have low lung volumes, you will get tired very easily. You might not be able to climb the stairs. You will feel short of breath. And the other thing is, so George, this one is for you as well, sir. If you have low lung volumes, then we tend to have secretion retention. So the phlegm stays in the lungs for longer because we're struggling to get air in behind it, and then we have difficulty in getting it out. And that will cause respiratory or lung complications, such as, for instance, bronchitis, pneumonia. Then the second component is, if you think about it, yawning, or if you're now getting bored with my lecture, then you'll probably sigh, okay, or then now specifically coughing that we've spoken about. That actually requires good respiratory muscle strength in order for us to do so. And it's something that I think most of us without NMD basically take for granted, but it is something that is a challenge for maybe some of you now, or it might become a challenge later. So how do we try and monitor this function, your ability to be able to cough, for instance? We've got a peak flow meter. I've got a picture there on the slide at the top for you. And most of you have probably been tested with this, or you've seen it. Some of you might have one. And this is actually a device where you take a nice deep breath in and you blow out. I'm just going to show you. I've got a pediatric one, so it's a little teeny tiny bit smaller. So we usually ask the patients to do 3 repetitions. So it's a deep breath in, and then we blow. Oh, I just have to get it on 0 first. Okay, you're supposed to relax your shoulders and you blow out. Okay, then that's peak expiratory flow, so that gives us the idea of lung volumes. But if we want to get an idea about the cough ability, then we'll ask the patients to cough. So deep breath in, and then I've passed the test. I got 360 liters per minute there. So because what they say is, let me just show you, that if a value falls below 270 liters per minute, that indicates that the cough is not strong enough to actually get the phlegm out, and you will require cough assistance, or we need to intervene for you. So that is what we can use, and these devices are really not expensive. So even for our local context, it is something that we can use to monitor our function. So that is the cough ability. So we're talking about lung volumes, and then we're talking about cough ability, and the third one is the mobility. Now, many of you have mentioned that, and I've already touched on the fact that upper limb function is related to your lung function. Because what happens is, as you grow older and as the disease progresses, the lung tissue, as well as the chest, the thorax, the trunk, becomes stiff and tight. And the problem with that is then it becomes even more difficult to take a nice deep breath, because you've got this tightness or stiffness. And here I brought a balloon to demonstrate. I usually use a balloon to do this. But if you think of a brand new balloon, it's usually quite difficult to blow it up. Those of you that do kiddie parties, quite difficult to blow it up. Sorry for the noise. There we go. But if we can do a little bit of like stretching of the lung tissue and the trunk, thoracic cavity, then it is much easier to blow up the balloon. Much easier. And this is basically what happens. As the disease progresses, you're going to develop restrictive pulmonary disease. So everything's going to become tighter. And a lot of what I will show you today is what we use to try and stretch a little bit to make sure that it's going to be easy to take a nice deep breath in. And then briefly, also towards the end, I will touch on inspiratory muscle training that we have performed here in our country that formed a great part of my studies, and just with what I found with our patients, because the idea was, besides some of the techniques that I'll show you, maybe inspiratory muscle training by training our breathing muscles within certain limitations, because remember we said we don't want to overexert or fatigue our patients, especially those with dystrophinopathies. So within limitations, if we can train, we might be able to still get the benefit of the training. So this little girl here at the bottom, she's got an inspiratory muscle training device, because in the end, what we want to do is we want to try and reduce the lung complications. We want to reduce the frequency of you getting bronchitis, pneumonias, lung infections, having to be admitted to hospital, and in essence, what we said previously as well, to improve your health-related quality of life. Okay, so let's move along. I hope you liked my story about NMD. And then I wanted to say, almost like a teacher, but I'm not going to say A is for apple. I'm going to say M is for monitoring. So one positive benefit or advantage that came from COVID, at least, is that healthcare services had to really start thinking out of the box and how we can start monitoring function as well. So there's been a lot of creativity, I think, and even from our patient sides on how to monitor their lung functions, and how we can keep an eye on all of you without you having to necessarily come to the clinic. And some of these we are actually still implementing because they're really of benefit, and the patients are very happy to have this benefit, and the healthcare professionals are happy to have the data so that we can keep an eye on you. So just consider, maybe most of you might have a smartwatch, you might have a pulse oximeter, maybe some of you have a peak flow meter. So these things we can use to actually monitor our heart and monitor our lungs so that we can know when we have to now go to the doctor and maybe consult. So just to again once more reiterate what I've been saying previously, and I'm just showing you, and this is why I'm saying proud as South African, what can we do within our South African context? Because some of the devices and the things that we use to measure inspiratory muscle strength, or the strength of the diaphragm or the intercostal muscles, I mean, they have to be brought in from overseas. And I mean, you can imagine anything being imported is going to be extremely expensive. So we have to think of solutions. And as we've also previously said, now the medical aid's not covering so many of the devices that are actually required. So let's try and keep it as cost effective as possible while we still try and maintain quality of monitoring and quality of intervention. So as I've mentioned, the peak expiratory flow and the peak cough flow with the peak flow meter that I've shown you, these devices are very easily available from your medical suppliers. As I say, they're really not that expensive, and it's an easy way of how you can actually test. So for instance, George, you can now test your cough ability and see that, oh yeah, I really do need assistance, without you realizing in any case, maybe that you're struggling to get the phlegm out. But we can also monitor, and some of you I know will probably draw up an Excel spreadsheet and keep your values in there so we can have a look at the trend. And I would love to have a look at that. Being a researcher as well, I like to look at the data. But this helps your medical team to see were there maybe regressions in your lung function, in your lung volumes, in your cough ability. Because if you do have a problem with lung volumes, if you do have a problem with your cough ability, then that might lead to the phlegm sitting in your lungs. We can't get it out, and that is going to make us ill. So very important for us to monitor that. And then we have a pulse oximeter at the top. I'm sure most of you know exactly what that is, because all of us have either bought them or used them during COVID pandemic. And this also helps us to just get an idea of what your heart rate is doing, saturation. But also just keep in mind that once your saturation starts dropping, if you have NMD, and because of the progressive respiratory muscle weakness, then most likely your CO2, your carbon dioxide, has already increased, because usually the carbon dioxide increases even before the saturation, before the oxygen starts to decrease. So that is why maybe your doctor might now and again suggest sleep studies so that they can actually measure your CO2 levels, because that is obviously also an indication to us that your lung volumes are low, and you might need to consider something like non-invasive ventilation, those devices that you can sleep with to help you breathe at night. And then we also, I've just sort of included them here. Here at the bottom, we've got the Brooks scale. So this is a scale that I've actually developed for patients with Duchenne muscular dystrophy. And I want all of you to quickly, you don't have to show me, so you don't have to put your cameras on, but just for yourself, just try and see if you can lift your arms and touch your hands then at the top of your head. To see if everybody can do that. I'm going to do it with you so they just show you. So we're going from the sides and we see if we can touch our hands above our heads. Right, and then you can now score yourself. Again, you don't have to tell me where you're at on this grading, grade 1, 2, 3, 4, 5, or 6 on the Brooks scale. Because, and by the way, it's an international scale. That's why they talk about Oz. But Oz is about 180 milliliters of water, just for you to know what you can use. But they then say, usually if we have a Brooks score of about 2 or 3, then that indicates there's a transition, not only of our upper limb function, but also of our lung function. And then some studies have also shown that patients that are presenting with a Brooks score of 5, that also correlated with them of having a forced vital capacity, lung volume then, of 50% predicted. So you can see that there is a correlation. As you lose your upper limb function, then that also links with a regression of your lung function. But I mean, again, we can do these tests very quickly without any equipment needed. And then if we do see that we're in a transition or there is reduction, then we know we have to go for further pulmonary function testing. And then there are also questionnaires for us to check if you want to see if you might have what we call nocturnal hyperventilation. So that just means having low lung volumes while you're sleeping at night. Because some of you might, if you do have that, some of you might experience headaches in the morning, more frequent nightmares, feeling very tired when you get up, not well rested, struggling to concentrate during the course of the day. So there are various sort of subjective signs that we can look out for. And then if you have these and you've maybe done the questionnaire, then once more to go and see the pulmonologist, and they might then suggest for you to have sleep study done so that we can consider using non-invasive ventilation. So these are just a few suggestions of what can be done in South Africa without needing a lot of money. Okay, now I'm not going to go into too much detail because this is what your pulmonologist or your physiotherapist will explain to you, but just so that all of us know why we do these things. So testing our lung volumes and our flows needs to be done once a year until we then start using the wheelchair more permanently, or then, as I say, as soon as your values start falling below 80%, so your forced vital capacity or vital capacity, then we should consider monitoring your values a little bit more often. So maybe then instead of once a year, twice a year. And they say as soon as your values are lower than 60%, you might require intervention. And the intervention might be getting a non-invasive ventilation machine. So those breathing machines, I'm sure some of you know of people that snore at night that have sleep apnea and then they sleep with the device. So that is a CPAP device, most likely. So these are devices that can help you with your low lung volumes during the night so you can sleep better and you feel well rested, you have more energy and you don't wake up with a headache. So our lung volumes here can also indicate to us when we should start using this. So also when it falls below 60%, you should start thinking of cough augmentation, of techniques on how we can stretch, in inverted commas, our lungs and our thorax and keep it mobile, but also for us to help with our coughability. I'll talk about that a little bit later as well. And then I've just shown you some of the results that I'm sure you've seen before when you've gone to the pulmonologist. Here right there at the top, there's a wolf that's trying to get the piggies out of their house by blowing it over. That's the function that we use usually for our children. They find that that's more fun, trying to blow the house down or blowing bubbles in a milkshake. And then right there at the top, we've got a device that is called the micro RPM. So the one you use the same device, but you can either put the probe in the nose or you can test it at the mouth. And this tells us then, as your healthcare professionals or your healthcare team, or then the researchers, what is your inspiratory muscle strength? What is your breathing muscle strength? And then based on that, we can also then determine if you might have problems with your low lung volumes and if you might consider inspiratory muscle training. So the forced vital capacity, like I've said, if it's less than 60%, we have to start considering intervention. So your SNP is the sniff nasal inspiratory pressure. That's the one where we tested with a probe in the nose. It works really well for people that don't have good oral control. So then we can also still test your inspiratory muscle strength. And then if it's less than 40, then we know there is breathing muscle weakness. And then also with the values here at the bottom, so if it's less than 70% of your PI max or MIP, that's the one where we measure it at the mouth. So your inspiratory muscle strength or pressure at the mouth, and that will also give us an indication that you have respiratory muscle weakness and we might need to intervene for that. Okay, right. Just a quick note for you, you don't have to really be bothered about this because this is what your physiotherapist or pulmonologist will most likely use. I know this article is really old, but it's we don't have a lot of evidence or a lot of formula to use. So, and this works quite well for us to get an indication if we don't have the micro RPM or these devices where we can test your inspiratory muscle strength or so either your breathing in muscle strength or your breathing out muscle strength, then we can calculate where it should be plus minus. So I have given some references because I know maybe you want to share this with your physiotherapist and then they can help you with that and you can decide on a treatment plan together. Okay, so just quickly, this is to summarize a little bit about what we've been talking about. And I just also want to say, hang in there a little bit longer. I'm almost going to give you a coffee break, a few minutes just to catch your breath and gather your thoughts. But this is a summary to just remind us that the two main components that people with NMD usually struggle with is that those low lung volumes that we've spoken about when we looked at the picture, which then sometimes causes what we call hypoventilation and then snoring at night, and the nocturnal hyperventilation specifically. And then on the other hand, also the poor coughability, not being able to get the phlegm out. So those are the two main components that as a healthcare team, we want to look out for and we want to address. So we want to work on those low lung volumes and we want to work on the coughability. So there we go. Now I'm not going to ask George or anyone else to tell me who is snoring at night. So that I will leave up to your family members or your wife or your kids to tell you. But a lot of times, and it's not to say that it is, but a lot of the times snoring in people with NMD can be an indication of hyperventilation or low lung volumes at night. So there are different devices to use. And I remember we also said if your lung volumes now fall, if the FVC is lower than 60% of predicted value, then we have to maybe consider using one of these devices. So we have the CPAP and the BiPAP. So CPAP stands for continuous positive airway pressure, and the BiPAP is also positive airway pressure, but it's got bi-level. So the difference is basically, so the CPAP pushes in air into your lungs then while you're not sleeping at a certain set pressure. But then as you exhale, there's no pressure, there's a bit of pressure relief. Well, with the BiPAP, you can actually set the two levels, the pressure that goes in and the pressure that comes out. And to be honest, this is the better option to go for if you do have NMD. I'm not getting any brown envelopes or kickbacks here, but the literature actually says patients have reported that they find it more comfortable, they have better outcomes because the CPAP sometimes doesn't offload the muscles, the breathing muscles, because the idea of using these devices is to keep the airways open for longer, because once you lie down, your abdominal content presses on your diaphragm, on your breathing muscle. And because of your breathing muscle weakness, it's almost like your thorax, your chest is collapsing a little bit. And that now adds to you not getting enough oxygen during the night and waking up with a headache and not feeling well rested. So these devices actually just keep the airways open for longer, but they also offload. It's almost like they're giving the breathing muscles a bit of a break so that they can rest and recuperate. And then once you wake up, you can get through the day much easier. So, but as I say, BiPAP is actually the one that is recommended for people with NMD because it's more comfortable, it's actually more effective, and it's because it offloads and it gives the breathing muscles a bit of a rest. And just so that you know, again, once more, medical aids might not always be willing to pay for these things, but there are also services available where people rent out these devices. If you maybe you've got a respiratory tract infection and just at the moment you're struggling with your breathing and you want to rent it maybe for 2 or 3 weeks, then you can do so. I can send the contact details through to Gerda. So there are those options available as well, because we know most of us can't afford to buy a ventilator or some of these devices, but fortunately there are people that can assist us with this. And then the cough mechanism, which I've previously shown you on how to do that. And we've spoken about what is a peak cough flow. Now, just to quickly clarify, so the first demonstration that I did, I blew out through the device, and then the second one, I coughed through it. Now, the difference is the peak expiratory flow gives us an idea of your lung volumes and the regression of your condition. And the peak cough flow is where the glottis, basically your vocal cords, are closing up. And that's where we hear the difference. So the peak expiratory flow, the glottis stays open, there's a flow of air, and the peak cough flow, it's more explosive, basically, because that is when we now try and get rid of those secretions. And that's why it's good for us to actually measure both. The one gives us an idea of lung volumes, and the other one gives us an idea of your coughability. So once more, we said with our forced vital capacity values, when the pulmonologist has now tested your lung volumes, if the FVC is less than 60%, you have to start considering ways of helping you with your coughability. You have to maybe start considering your CPAP or BiPAP, preferably BiPAP devices, but then also just to give you values. They say if the forced vital capacity is less than 2.1 liters and the expiratory volume in 1 second is less than 2.1 liters per second, then this also is an indication that you should actually assess your coughability and monitor it a little bit more often. So I'm just giving you some values so that when you go to the doctor, you will also understand what they're presenting to you, and then you can also ask the right questions. And don't be afraid to ask the doctors the questions. By the way, they also don't know everything. So sometimes we can also teach them, and I've many times learned so much from my patients, so go for it. Okay, now I just quickly want to explain, and this is really the bare basics of what a cough consists of. So I think other people are coughing already. Thank you, we're warming up. Okay, so basically a cough has got 3 stages, which I've depicted for us here. So we take in a nice deep breath, okay, which our respiratory breathing muscles is now responsible for. So those intercostal muscles in between the ribs, your diaphragm, your primary breathing muscle, these ones, the diaphragm moves down and intercostal muscles move out, and in that manner, air flows into the lungs, okay? And then the glottis or the vocal cords close up to keep the air inside the lungs, and then we build up pressure. If you can imagine what now happens to that air, pressure is going to build up, and we need that pressure because then in the 3rd step, when the glottis and the vocal cords open up and the diaphragm now moves up and the intercostal muscles also contract, and then if you cough a little bit harder, your abdominal muscles, your expiratory muscles will also contract to cause a nice explosive action so that we can get a very high flow of air moving out of the airway so that we can get rid of our secretions. Okay. So now I would like all of you, there's a Winnie the Pooh again, so that means you're going to do something. So I want all of you to, first of all, you can switch on your mics if you want to. You don't have to switch on your videos, but use your mics so that we can hear you. But I want you to take a very small breath, like a low lung volume, not a big breath, just a small breath, and then we're going to cough. So a small breath and then cough. I want to hear a few coughs. There we go. Okay, that was with a small breath, right? Now we're going to take a deep breath in and then cough. So deep breath in and cough. Good. Oh yeah, that's a coughing choir. Well done. I think maybe we can go and make a CD. Well done, everybody. So I hope that you felt the difference and that you also heard the difference. So if we have a small breath in, the cough is not as strong as compared to a big breath, because a lot of the times people are under the impression that the expiratory muscles, your abdominal muscles, have to be strong so that we can increase the flow and just get the air out. That is true. That is definitely also true. It's part of the coughing mechanism, that 3rd step. But I think all of us have now realized we need what we call a pre-cough volume. We need to have a bigger breath in, because the more air we've got inside, so the lungs, to build up the pressure, the greater the flow is going to be when we cough. And that is where the inspiration and the insufflation is going to come in. Okay, but well done on the coughing. I really think we did a great job there. Okay, now I want to first of all apologize to all of the males. I do not know cars very well, but I like to use this metaphor, so I hope you're going to appreciate and enjoy it. But this is just to have a visual representation of what we actually need to have a good and effective cough. So on the right hand side, we've got a very smart, snazzy looking car that's obviously very fast. Now this is when we have a normal big cough flow. So if we have enough muscle strength to have a good effective cough and get the phlegm out of our lungs. Okay, so they usually say that we need more than 400 liters per minute as we measure it on that peak flow meter. So the average is very difficult to say because it depends on the age and the sex, but the range is usually can be from 400 to 1,200 liters per minute. But the bottom line is we need more than 400. Now, unfortunately, if you look on the left-hand side, that rusty Volkswagen Beetle, unfortunately, that is what happens when we have respiratory muscle weakness. Okay, and also when you have progressive respiratory muscle weakness, and even more so if you have a respiratory tract infection, because usually what happens when you do get an infection, either in your upper airways or lower airways, your cough ability reduces. So it doesn't even matter what your baseline cough ability was before you fell ill. As soon as you fall ill, the cough ability reduces. So that is why we have to try and keep our cough ability as high as possible and as good as possible, so that even when we fall ill, it doesn't drop too far. And that's where I've shown you previously the 270 liters per minute is the cutoff point that the clinical guidelines tell us. And this is for children 10 years and older, and then obviously for adults. So if your cough ability, if you do the peak cough flow and you see it's less than 270 liters per minute, that indicates you need cough augmentation, you need assistance with your cough. It's not strong enough. And then usually when people fall ill, it can even drop below 160 liters per minute. And this is then where we start developing bronchitis and pneumonia, because the secretions are just sitting in the lungs and they make us ill. So what we try to do is, with some of our treatment techniques, is to move your cough ability from the rusty Volkswagen Beetle in the direction of that fast car. Now, we might not necessarily always be able to get you to the levels that people without NMD might have, but we try and get something in the middle. So the golden midway there will be an old sports car. So, gentlemen, I hope you enjoyed that metaphor, but that's what we basically try to do. We go from the left-hand side and we'll move towards the right-hand side to improve your cough ability. And I included a picture here just of healthy skeletal muscle and then Duchenne muscles, just to remind us that this is what your breathing muscles then also most likely will look like, because we've got fatty deposits in between, and it's not only muscle fibers, and that's part of the reason why the muscles are so weak and we're having difficulty with our coughing. And that is again why it's important for you to monitor your cough ability. So at least then once you've lost ambulation twice a year, and a minimum while you're still ambulant and walking once a year. But I mean peak flow, peak off flow, you can even monitor that very easily at home.
Sorry, Anri.
Yes.
Just a question from Raj.
Yes,
He
Raj.
wants to know how effective are the massage chairs, that is the genuine medical chairs, or the ones that you buy at a retail store with the upper back beating mode. I think it's to loosen phlegm or something, those massage chairs.
Thank you. So if you have an extra one, Raj, you're welcome to send it along to me. I wouldn't mind. Okay, but thank you. That's a very interesting question. You know, the problem with those devices, I mean, they are very nice in the sense of loosening the muscles, and sometimes we do have tight muscles which can then affect our breathing and our mobility. So for that reason, I think it is quite helpful. If you think of the sort of the percussion part of it to loosen the phlegm, the problem with that is it's not a human being. Sorry for the pun, but with humans, with us as physiotherapists, or even with a caregiver, they can adjust the percussions, the speed of the percussions. I mean, how hard you're actually performing the technique. Well, that machine or that device is set to a certain frequency, and that's what you're getting. And a specific frequency is actually needed in order for us to mobilize secretions. So I want to say it might be helpful to a certain extent, rather than having nothing, but it's probably not going to be as effective as having a specific physiotherapy treatment, or let the physiotherapist teach the caregivers on how to do it, because sometimes the areas of where the secretions and the phlegm might not even be the areas there where you're getting the movement from the chair. But I mean, I'm sure all of us would love a massage chair, and it helps for circulation, it helps for relaxation, it helps for pain relief. So it has a place, but I think when it comes to addressing the respiratory or the lung problems, it might not be as effective. I hope that answers your question.
Thank you very much. Sorry, I'm actually asking these questions on behalf of parents. During our KZN MD Awareness Day on the 17th of September, a request was made to parents or affected members to submit their questions that they would like to ask at this webinar. And so far we received 11 questions. Most of them were common questions, so I'll ask the questions as we go along. And I think I've got one more question that I've also sent through.
Thank you. That's very proactive. I actually like that idea. Maybe we can consider doing that next year for Gauteng also. Ask our members to send through some questions, and then we can answer them.
Yeah, and then one of the questions was, in fact, there was from the 11 questions, I've broken it down to 4 because most of them were common questions. So you've answered the first question. The second question is, what has been done to create more awareness at hospitals' trauma units and the wards on how to treat and handle affected members with MD? Because from the feedback that I've received, when this questions was posed to us, is that there's a lot of confusion at the provincial hospitals and even the private hospitals on how to treat MD patients.
I hear you. I think that's what most of us have been encountering as well. I don't know if Gerda wants to maybe answer that question. I know from my side, obviously we have what we call CPD lectures, where we then get healthcare professionals in and we present these lectures, on NMD and how patients present. So that's one way, obviously with our awareness days as well. And I know, I think in America it's a parents project, muscular dystrophy group that have also got these cards. So I can't remember, Gerda, if we've done something similar that we can distribute at the ER units so that they will understand what type of anesthesia they're not allowed to use and what patients present with muscular dystrophy and what they should consider. Because the other thing is as well, they shouldn't only give oxygen when the saturation is low. It should be accompanied with cough augmentation and or ventilation, because a lot of the times the low saturation is caused by hyperventilation or secretion retention, and not necessarily just by, it's not going to help to just give the oxygen, because then we actually suppress the breathing area in the brain. So that's also very important for us to get that message out. Gerda, can you?
Anri?
Yes.
Yeah. The foundation, we have developed emergency cards. It is wallet size, so you can keep it with you. We have been distributing it now for a couple of years. So if you don't have your wallet size card, please drop me an email with your type of muscular dystrophy and your postal address, so we can send it on to you. We also have it available on our website. So if you want to print it out, you can also do that from our website. But yes, we do have emergency cards available.
Thank you, Gerda. I'm aware of that. But just if I can recommend, perhaps we can do ongoing reminders in our digital magazines that whoever has not received their cards to please contact the nearest office.
That's a good idea. Thank you, Raj. Nice. Thank you so much. Right, so thank you for also being, as I said, proactive and getting questions. I'm going to just maybe see if we can get to the point where I'm going to give you a break, and then Raj, I'm going to ask you to please then give us the rest of the questions also a little bit later. Thank you so much. But these ones are very valuable, and I think it's good for us to even to share this information on a forum such as this, so that everybody is aware. And I think all of us should actually maybe have, I'm going to ask you, Gerda, I'm also going to order a few cards so that I can hand them out here at Steve Biko Hospital and some of the other hospitals that I go to. Again, once more, it might be one person or one small little act, but it might just save a life. So let's go for it. Like I said, I'm super motivated once more by all of you. Thank you. This is it might seem like a little bit of a daunting picture, but this was published by, I just adapted it, I made it a little bit more smiley and more pediatrics, but it was published by Chapman and colleagues, and they just basically explained that getting phlegm from your chest, so what we call airway clearance techniques, can basically be divided into two main sections. So the one is peripheral, and all that means is actually to get the phlegm from the farthest areas of your lungs to the central airway, so that you can actually get it out. Now and the ways that we do that might be with percussions and vibrations, and sometimes with your breathing exercises. So I'm not going to focus on that today. If you would like more information, I can share with you, or we can have another session at some stage. My focus is going to be more on the proximal airway clearance techniques, and this is so now when the secretions are within the central airway, but we're struggling to get it out because of either having this respiratory tract infection that is now reducing our respiratory muscle strength, or just even without the infection, we're just struggling to get this phlegm out because of the respiratory muscle weakness. Now, the proximal airway clearance techniques can be divided into assisted inspiration, assisted expiration, and then doing a combination of the two. So if you remember correctly, this links with what I previously showed us with the cough mechanism. So assisting the inspiration, getting that good breath in, assisting the expiration, that expiratory flow, and then doing both of them. Okay, so now I'm hoping and praying that this video is going to work, but I'll just quickly mention so that you know what this is about. So assisting the inspiration, now we want to make sure that that pre-cough volume is actually good enough. So to take a nice deep breath in, there's a lot of ways of how we can do it. We can either spontaneously take a nice deep breath in, or you can do what we call glossopharyngeal breathing. The other name for it is frog breathing. That's why I've got the froggy there. And we're going to see if we can play the video for you now so that you can see how that is done. But the frog breathing is basically just using your tongue and your cheek muscles and your throat muscles. And you're basically forcing the air. You bring air into your mouth and then forcing it to the back of your throat and sort of gulping it down so that you get air into your lungs. So it's almost like blowing up the balloon. That's why I've added a picture of a balloon here. So that's one way of doing it. Another way, like I said, with spontaneous breaths, and then we can do what we call breath stacking. So a breath in and hold your breath, and then in, hold your breath, and you keep on stacking, and then you can cough. And then another way of doing it, if your muscles are weak and you're struggling to do breath stacking or doing it by yourself, you can even use an ambi bag. So most of us might think that this is only used in the ER room when they do resuscitations, but for people with NMD, this is really super helpful because hopefully if this video now plays, Eric is going to show you how he does it, but you can either use a mask or a mouthpiece, and then that is actually like blowing up your own balloon. You're getting air into your lungs so that you can then have a better cough effort. So I'm hoping and praying this is going to work. So let's see, going for the ambi bag one. Air stacking with the ambi bag. Here we go. I hope our sound is going to work. So thank you very much.
So I have limb girdle muscular dystrophy.
Yes, it works.
And my lung capacity is compromised. So I do struggle to cough. And what I'm going to demonstrate is an apparatus called an ambu bag. And I use it to do something called air stacking, where I force quite a lot of air into my lungs. And I inflate my lungs. And on exhalation, I have more air in my lungs, which creates more pressure, which helps me to exhale and cough and expel the liquids at the same time. Okay, so I'm going to demonstrate the ambu bag, and this end goes into my mouth. So I'm getting a cough that I wouldn't usually be able to get without stacking the air.
Okay, beautiful. I'm so happy that that worked. So now we can see the other use of an ambi bag, not only doing resuscitation. So let's get to the frog breathing, or also known as glossopharyngeal breathing.
So I'm going to demonstrate air stacking, but using a manual way. So I'm not going to be using the ambu bag. And this is something you can do if you don't have an ambu bag. You can use the air stacking technique to clear your lungs. I breathe in and then I gulp the air. So what I'm doing is I'm taking as deep a breath in as I can, and then I draw the air into my mouth and I push it downwards. It does take a bit of practice to do air stacking this way, and it takes a lot more breaths to actually fill your lungs. The ambu bag is a lot faster.
I hope everybody enjoyed that. Thank you once more to Eric for being such a good actor and collating these videos for us. So remember now we're assisting the inspiration, the taking a deep breath in, because we said we have to improve our pre-cough volume in order for us to have a bigger and a better cough to be more effective. And the other thing is, I'm sure most of you probably also stretch your ankles to try and keep them from not becoming too stiff. So this is also what the ambi bag or the breath stacking or the breaths will do. It just helps to, it's almost like stretching your lungs and stretching your thorax to prevent them from becoming stiff, because we've said that we tend to develop that restrictive pulmonary disease. Okay, so now I want everybody, now we're going to, they say we have to practice what we preach. So we're going to wait for the circle to come around, and I want you to take now a nice deep breath in through the nose, deep breath in, and then hold it, hold, and breathe out. Now remember to put your hand on your diaphragm, deep breath in, make sure the diaphragm moves down, the abdomen moves out, hold it, and deep breath out. And one more, everybody ready? Deep breath in through the nose, relax the shoulders, hold it, and breathe out. Well done, everyone. And coffee time is coming. Just hang in there for me a little bit longer. So now we've shown you how to do assisted inspiration. Now I'm going to talk about how to do assisted expiration. So the expulsion part. Now this you can do with, obviously maybe your caregiver or a family member or a friend can help you with this. We can either do compression on the abdomen, on the tummy, or we can do compression on the chest, on the thorax, or sometimes we even do compression on the tummy as well as the thorax. Like you can see my colleague Michelle Toussaint here at the bottom is giving compression on the abdomen as well as the chest. So we obviously have to coordinate that with the person that is coughing. So you're going to ask them, okay, take a nice deep breath in, and as they breathe out, then you give a compression. So it's almost, if you press on the tummy, it's almost like a Heimlich maneuver. You press in and upwards, because it's almost like we're taking over the function of the abdominal muscles, of your expiratory muscles, to make the flow of air that goes out a little bit faster. So we're taking some of the function of the abdominal muscles, and when you press on the thorax, the function of the intercostal muscles, the muscles in between the ribs. I just want to here say that please do not do the abdominal compressions for children younger than 10 years of age. So if you've got a boy with Duchenne muscular dystrophy and he's 7 years old and you want to assist with his cough, please rather do it on the chest, on the thorax, because with children, usually the abdominal aorta, one of their big blood vessels, is a little bit more superficial and we don't want to cause any damage. But then older than 10 years, we can do the abdominal and thoracic combined. It's also going to depend on the person, on an individual. Some people prefer having both. Some people prefer doing it themselves even. So you'll just have to ask. I've also then included some videos for you that you can go and have a look at later on. But I'm now going to show you one of Eric's videos once more. And this is you'll see why I've put a laughy face there, and local is lekker, because I want to also say, please don't try this at home unless if you know what you're doing. But he's now showing us a technique, what we can do to increase the pressure and increase the expiratory flow if you're by yourself and you might not have an assistant. So let's see what Eric shows us. As I say, I found this very entertaining. Our patients and our members are very, very creative.
I have limb-girdle muscular dystrophy with compromised lung function and weak intercostal muscles and a weak diaphragm. So when I've got phlegm in my lungs and I need to cough, it's difficult for me to gather enough strength to cough the phlegm out of my lungs. So I'm going to do a bit of an unusual, I'm going to demonstrate a bit of an unusual method to do this. And I'm going to use the corner of the basin here. So you may have something similar to this or a tabletop. Make sure it's not too sharp, because you're going to drive your wheelchair, if it's a manual chair or a power chair, into the corner here, so that it is in your diaphragm. So let me just show you this. So you drive your wheelchair like that. So it actually pushes the air upwards manually. Okay, so I would go if I had phlegm in my lungs, it's the most incredible way of getting the phlegm out. Very, very effective. Far more effective, I found, than even the Anri bag and the air stacking.
Thank you so much to Eric for giving us an alternative way of doing it. So the idea is, once more, you just want to increase the pressure basically within the thorax, within your chest, so that we can increase the flow of air. So that's the idea behind it. So now combo, I think most of us like a combo. So to be even more effective, we can do a pre-cough volume, so we can increase our taking a deep breath, and then we can, on the expiration, we can give assistance. So that will be the combination of the two. And we can do it manually, like we said, with now taking a deep breath, or breath stacking, or frog breathing, or the ambi bag, and then manually assisted cough. So we can do compression on the abdomen, on the tummy, or on the thorax and the chest, and we can do both to be even more effective. And especially also as the disease progresses, then maybe the breath stacking might not be enough, or then if you have a respiratory tract infection, you might need a combination in order for you to actually be more effective, to get your peak cough flow high enough for you to get the phlegm out of your lungs. So here we've got you can go and have a look at the video a little bit later if you want to. And I'm sure some of you might have experience with what we call the mechanical insufflation exsufflation device, or a cough assist device. Unfortunately, once more, these are imported from overseas and they're really expensive, but you get different types. Philips Respironics, they produce one. There's a nippy Clearway, there's a cough assist. But basically how this device works is you can either use a mouthpiece or a mask, and you can even connect it to a tracheostomy. And then it pushes air into the lungs, like blowing it up, like that insufflation part, and then it immediately switches to a negative pressure and it pulls out the air out of your lungs. So it's the exsufflation. So it's like a into the lungs and then it pulls it out. So it simulates a cough, basically. It sounds almost like a vacuum cleaner because it's quite loud, pushing the air in and pulling it out. The problem is this, with the pressure, it's sometimes difficult to determine what is safe. There's always, obviously, when you push air in, or when there are pressure changes and volume changes in the lungs, there's always a bit of a risk. And that's why we said with all of these videos and with everything that I'm presenting now as well, please don't go out and buy a cough assist device and just do whatever pressures you like or you love. Please consult with your pulmonologist or physiotherapist, because we'll be able to guide you with regards to what are safe values to use. And especially you'll start with lower values and then move up. And I know some patients or some family members might have these devices, and they're very useful. They are also recommended by clinical practice guidelines, but especially when it comes to children, again, younger than 10 years of age, we have to use lower pressures. And I would like you're welcome to contact me. I can always share with you. Excuse me, now I've got a frog in my throat. It must be the frog breathing. I can always share with you a guideline that we've developed that's actually currently being used at Red Cross Children's Hospital, because there they do have the cough assist devices. So many of the children with NMD actually receive this, or receive the treatment when they're in hospital. And some of the parents have also bought these devices, so they're using them at home. But we do have, as I say, a specific protocol, especially for children. We have to use lower values because we don't want to cause any damage within the lungs. But patients have also said, from a subjective point of view, that these really work very well for them. They can get the phlegm out easier. But again, we always have to consider costs. And that's why I was saying, depending on the resources, we might be able to use a cough assist device. Some patients will also use a cough assist, even combined then with manually assisted coughing. So they will use the device, and then one of the caregivers will also even give compression on the abdomen or on the thorax to increase that peak cough flow even further. But I think a lot of the times we feel a bit down in the dumps because we don't always have access to these resources. But we don't necessarily have to, because research has shown that using the ambi bag, using the breath stacking, the frog breathing, combined with manually assisted cough, can be as effective as using a cough assist device. So please don't despair, everyone. And I'm not going to go into detail. This is just welcome to look at this later, and I can also share the article, but it was published by my colleague Michel Toussaint from Belgium. And they basically just said, and it links again with what I told you earlier, that when your forced vital capacity falls below a certain level, so the 60%, then you have to consider bringing in cough augmentation. If your peak cough flow falls below 270 liters per minute, we have to consider bringing in assistance intervention to assist you with your cough. And then obviously the lower it becomes more red, the lower the values, then definitely there is a need for cough assistance. So this is a summary of everything that we've done. And then I'm going to maybe give a quick chance for one question if you have, and then we're going to get to that coffee break. I'm sure all of you are already boiling the kettle and getting ready for the cup of coffee. Maybe one question.
Okay, one question from KZN. They want to know, what is the treatment difference between a physio and chiro? They assume it's a chiropractic treatment. So what is the difference between physio and chiropractic treatment?
Thank you so much for that question. The chiropractors are more specialized in, I want to say, like spinal, so on the spine and your back and neck manipulations, and realigning the patients and helping them to minimize the asymmetry. Well, physiotherapists, we have a quite a broad scope, so we also attend to, we can work on the neck and the thoracic area and the lower back, but we also train then in the respiratory side, like what I'm presenting today. So in South Africa, physiotherapists are generalists. So once they qualify after their 4-year qualification, they've done a component of research as well, but then they can treat numerous conditions, pediatrics, as I say, neck, back problems with the heart, problems with the lungs. So I think, but then obviously some people will specialize. So in my case, I specialize in pediatrics, and then later on now in NMD. Other people might specialize in women's health or in cancer, etc. So with the chiros, I think they will help or assist more with mobility and maybe pain and alignment, while physiotherapists will be able to also help with the mobility, but also assist then with the cardiorespiratory, so the heart and the lungs. And then we also do pain management. So there is quite a number of areas that we overlap on, but the chiropractors usually don't address the respiratory or the lung functions because they're not qualified for that. It doesn't fall within their scope of practice. I hope that answers the question. Thank you very much. Hope all of you are back and ready for a little bit more. We've now, just to quickly recap, we've covered about what can be done for low lung volumes and poor cough, and we've thought of and we've seen a few ideas on treatment strategies. And now I'm going to talk a little bit more about, say, some of my favorite parts and inspiratory muscle training. But I must say, it's from one of my favorite movies. I don't know whom of you have seen the movie by Patch Adams, but I think this is the vision and the passion that all of us have, specifically considering that at the moment we do not have a cure for NMD, but we do hope to be able to improve health and quality of life and just make sure that you've got the best life ever, as far as possible and as we can. Apologies, I don't have a red nose for today, but I do have a big heart for the NMD community. So now I can talk about what lies really close to my heart. I promised you that we will talk a little bit about inspiratory muscle training as well. So I'm saying that this is made in South Africa because I'm going to present some of the results from my research that was done in South Africa. So this is really local is lekker, very context specific. Okay, so I would like us to think of and consider inspiratory muscle training. So this is basically devices that we use. So it's similar to using a dumbbell in the gym where you want to now strengthen your biceps and make it look bigger, so that you can get the attention from the girls, or be able to lift boxes easier, I might assume. But these devices basically do a similar thing, and that's got a similar purpose, so that if you breathe in against a certain resistance, so that actually then makes your breathing muscles stronger. So we get inspiratory muscle trainers and we also get expiratory muscle trainers. So for instance, in Duchenne muscular dystrophy, your diaphragm, your inspiratory muscle is more affected, while with limb-girdle muscular dystrophy, they tend to present more with abdominal weakness, the expiratory muscles. So depending on the clinical presentation, we might decide to then either strengthen inspiratory muscles or expiratory muscles, but the training is specific. So if you want an improvement, obviously, in your expiratory muscle strength, then you have to train your expiratory muscles, your abdominal muscles. If you want an improvement in your inspiratory muscle strength, then you have to work on the strength of the diaphragm. So what we can also then consider is as I've previously shown you, and you've also done it yourself and we've demonstrated, we need a pre-cough volume. So even if your abdominal muscles are maybe more affected than your diaphragm, if you can strengthen your diaphragm and you improve your pre-cough volume, then your cough will most likely also improve. So I'm going to show you some of our findings, some of the results. So we published a systematic review, and for those of you that are not maybe in academia, a systematic review is like a summary of many publications so that we actually save you a lot of time. We summarize it for you so you can go and read one article, and there's quite a bit of work. But what we found is, because we specifically looked at children and adolescents, because there's very limited evidence and very limited research in this field. And the studies that we've summarized within this article basically indicated that there are possible advantages of inspiratory muscle training. And there are maybe then also those that are a bit cautious and are thinking of the risk factors. But based on this, what we found was that we didn't have specifics to actually guide our clinical practice, to tell us what type of protocol we should follow for training, what should we do, how should it be done, is it to the patient's benefit, yes or no. So our summary basically said more research is required. And I've also, for your reading and watching pleasure, I've included another link here that you can go and have a look at. Also just a summary that was given by PowerBreathe, which is one of the manufacturers of an inspiratory muscle training device. And they've also now recently brought out an expiratory muscle training device. So our summary said we need more research, and then we said, okay, let's go and have a look at what the physiotherapists do in South Africa. So I won't bore you with too many research and statistical tidbits and information, but what it boiled down to is we looked at standard of care, and we asked the physiotherapists that are involved in cardiorespiratory care and management in patients with NMD, what they actually do, what they've been doing over the past 6 months, what are their opinions, do they know about clinical practice guidelines? And we did find that they were aware of the clinical practice guidelines and the recommendations, but they still preferred the more traditional airway clearance techniques. Now remember the diagram I showed earlier about the peripheral and the proximal airway clearance techniques. So interestingly enough, what came out from this study is that very few of the physiotherapists were actually using ambibags, although they have been recommended in literature in the clinical practice guidelines. So that's also part of my reason why I'm presenting this today, so that you can go and ask your physiotherapist about the ambibag and ask your pulmonologist, so we can raise this awareness. I think awareness and knowledge has been the main theme coming through here this morning. And I really think this is important for us, because an ambibag is not that expensive. So if you can get hold of one, you should be able to get it through the medical aid. Alternatively, I mean, I'm sure we can also look at fundraising opportunities to do this, but I really think we should get an ambibag in the hands of every single patient with NMD in South Africa, because like Eric said, it's really helpful. It helps him. We can prevent some of these complications. So this is one thing that came from this study. And the other thing is, we want standardization of care, in the sense that we want every patient with NMD in South Africa to be able to get the best care possible. But we can only also, again, do that through advocacy, through awareness. And that's part of, I guess, my job is with the publications and with doing presentations, so we can get this message out there, and also tell patients about the ambibagging, the breath stacking, the manual assisted cough, even though you don't have a cough assist device, but if you do, you can use it, but then how to use it in order for us to make sure that we're still safe. So I must say our findings were very interesting, and it helps us to also guide our clinical practice and what we need to teach at undergraduate level and then at postgraduate level for our physiotherapy colleagues. And now here we actually published a pre-experimental study. So what we did was, after the summary of the systematic review, we realized, okay, more research needs to be done. We don't have specifics to guide us. Then we got information from the survey that we performed among physiotherapists in South Africa. And then we now did a trial run, or a trial study, that included 8 participants within Gauteng. And we asked them to train with this specific PowerBreathe K3 device. Now, it is quite expensive because it's electronic, but the reason why we had to use them is because we wanted to actually collect data. So it stores data for you on the device. But we asked our patients then to do training with this inspiratory muscle training device twice a day, 30 breaths, and then We did that for 6 weeks. So there was a 6-week intervention period, and we monitored quite a number of outcomes. We looked at the upper limb function, the lower limb function. We looked at the upper limb function coordination. We looked at their lung volumes, their flows, their inspiratory muscle strength, the SNP and the PI max, for instance, the cough ability. So we really had quite a number of measures that we tested, but they then performed this training. And what we found was that it was very exciting. The results and the outcomes is that there were no significant changes over that 6-week period for spirometry, so for the lung volumes, which I must say was actually expected because it's a short time period, and in NMD we would actually rather expect a regression than an improvement. So I know one of the colleagues, Prof. Mercury, has always said if we can just maintain some other lung volume or function, then we've already won when it comes to NMD. So we didn't see significant changes in the lung volumes or the cough ability over the 6 weeks, or then health-related quality of life. We measured this by making use of a specific questionnaire named the PEAT score. But also what was very important from a safety point of view, after the 6 weeks of training, we did not find any adverse events, which was great. So no adverse events, negative things associated with the inspiratory muscle training. And the overall patient satisfaction was really high. I mean, these kids were loving it. They loved doing this. They performed the exercises. They were very compliant. But what did we find with regards to their pulmonary or their lung function? So I've just highlighted a few of these. So the PIF stands for peak inspiratory flow. So statistically significant after the 6 weeks of training. If we look at the ability to take a deep breath in and to create inspiratory flow, it was much, much better. Also looking at the PI max, which is measuring the inspiratory muscle strength at the mouth. That was also statistically significant better after 6 weeks. The strength index is similar to your PIF, and you can also see the p-values are similar there, but that just basically gives you a global indication of the inspiratory muscle strength. So inspiratory muscle strength, the ability to take a deep breath in, that improved after 6 weeks of training, twice a day, 30 breaths. But what was surprising, what we actually did not necessarily expect, but it links very well with what I've told you earlier, I said there was a statistically significant improvement in the upper limb function and coordination. Now, I guess if we think of the theory that the breathing muscles are also stabilizing muscles, this will make sense. So if those muscles become stronger, then my upper limb function might also even become better. So that is something to consider, and it will have to be confirmed with larger trials, of course. And now, being in Africa and being a pediatrics lecturer, I have to tell you a bit of a story. This story is now about the last phase of the research that we performed, because we had the summary of literature. We found out from the physiotherapists what they were doing and if they knew about the recommendations. And then we had this trial run of 6 weeks. So now we're moving a little bit further. So I'm going to tell you a story. So once upon a time, there was a boy named Ben. He was feeling a bit sad because he was diagnosed with Duchenne. From an early age, he had difficulty with walking, running, and play, and recently uses a wheelchair to help him on his way. Besides the inability to walk, he has difficulty with breathing and cough. And with a deep sigh, Ben thought to himself, I wonder why. Now you might remember this picture, the one that speaks 1,000 words. So this answers Ben's question. Because of the progressive respiratory muscle weakness, we've got the low lung volumes, decreased cough ability, and most likely development of restrictive pulmonary disease, which will lead to secretion retention and decreased airway clearance. So now, as I've shown you, we've thought of inspiratory muscle training and what that could possibly do. So our further step and our advancement was now to ask patients to train for 3 months instead of just 6 weeks. Also, again, 30 breaths twice a day. We use the Power Breathe K3 devices, and the training intensity was set at 30% of their inspiratory muscle strength, because we wanted to be safe so that we don't overexert the patients. And that's why we also use this scale, it's called the Omni scale, to monitor their level of perceived exertion. So again, as with the pilot study, we looked at adverse events and their lung function, motor function, health and quality of life. We asked them to keep training diaries for us, and once more, our patients were really very committed. And what we also did was, after the 3 months of training, we took the devices away and they stopped with the training, but then we followed them up for another 3 months because we wanted to see what was the effect, or how long could the effect of training actually last. So then that's what we did, and what we found was actually quite interesting. So we had 23 participants from 2 provinces. So they were from Gauteng and the Western Cape. Majority obviously with Duchenne muscular dystrophy and spinal muscular atrophy, and very importantly, once more, no adverse events. However, there were also not a difference in the rate of hospitalization and respiratory tract infections between the training and the non-training period. But I mean, it might also be explained by the fact that the patients were only training for 3 months, so maybe a longer period might be required. But that will also, we'll have to confirm that with longer and larger randomized controlled trials. Again, also with the spirometry, the lung volumes, we didn't find any statistically significant difference between the training and the non-training, as well as the functional ability and the health-related quality of life, the total scores. Interestingly enough, the child-reported physical ability scores actually showed a statistically significant improvement or change between the training and the non-training period, which was completely unexpected. But I mean, the children, according to them, could physically perform better after their training. And the overall patient satisfaction, again, was really high and adherence was good. One of my most favorite slides is the one where I can now show you that there was a statistically significant improvement and a difference between the training and the non-training period for the inspiratory muscle strength, so the diaphragmatic and the intercostal muscle strength basically, as well as their cough ability. So yay, this basically confirms what we've been saying about if you can have a better pre-cough volume, then most likely your cough ability will be better. And this diagram on the side also shows you the change in the inspiratory muscle strength over this 12-week period. And as you can see, remember that first study, we trained for 6 weeks. Even after the 6 weeks, it was a little bit less than for the first 6 weeks, but there was still upwards movement or trend towards an increase in inspiratory muscle strength. So this is really exciting because it shows that within safety limits, people with NMD can do inspiratory muscle training and hopefully get the benefit because there's an improvement in inspiratory muscle strength and then in their cough ability. Now remember the story about Ben that had difficulty with breathing and cough because of Duchenne. His friends were elated about the findings of the study and went to share with the good news in the hope to chase away his blues. Ben, we bring good news to brighten your day. Children with conditions like yours, after performing IMT, had the following to say. They can now take deeper breaths, they feel better, and it's so much easier to cough. Let's not wait any longer. IMT can make your breathing muscles stronger. Ben smiled as the rain clouds disappeared, and he saw a ray of hope, and thought to himself, maybe my friends are right. I can do my part and make my diaphragm stronger, so I can sleep better at night and stay healthier for longer. So let's step into the future together. To train or not to train? Yes, you can. So in conclusion, based on the inspiratory muscle training that we performed, we want to say that it seems, based on these results, which we are very excited about, that inspiratory muscle training among children and adolescents with NMD seems to be safe, viable, well tolerated, and effective, especially when we look at inspiratory muscle strength and cough ability. So although this might be, or the results is the end of one story and maybe the end of Ben's story, it's not the end of research in this field. And I think even with today, we are taking hands, and we need to do, from a research and academic point of view, we need to do more research, but we will definitely need your assistance with this, because together we are stronger. And it's not the end of this story, because we are continuing, and we are continuing with the research because we want to improve your health-related quality of life. So in conclusion, again, please excuse me once more, being a pediatrics lecturer, I have to provide a quote from The Lion King, Pete's movie, of course, but I think a lot of adults also like this movie. But I want to say a lot of things might have happened in the past that we might feel sorry about, or we didn't start early enough, or we would have liked to do more, but the past is gone. Let's look towards the future. And I'm very excited about what's currently happening in South Africa and in the field of NMD. And I am so, as I said earlier, super motivated and so grateful for all of you being here. But together we can make the change. But we will have to take hands and do it together. And then last but not least, I would like, if you would allow me, before we can get to a few more questions, I would like to share a poem that I wrote quite a number of years back. It was actually as part of the celebration of Duchenne Muscular Dystrophy Awareness Day. And I would just like to share this with you because I feel all of you are family, and I would like to tell you about my red balloon family. My muscles are aching, and I don't really know why. At school, I can't keep up, and during playtime, everyone passes me by. Getting up from the floor, a challenge for me. Go a sign, the doctor says. What will that be? I get so tired and have to catch my breath. My mom says I'm a hero because I never give up and always get by. Forget about Superman and all the rest. But I surely don't feel like one. Wish I can put on my cape and fly. One day, very soon, I want to be there to hear it too. A cure for my lack of dystrophin and hope for the future. Please join me, won't you? A red balloon, especially for me, to raise awareness about Duchenne muscular dystrophy. If all of us can work together as a family, we can improve our lives and create a beautiful tapestry of hearts weaved together with one goal in mind, to make a breakthrough and a cure to find. So next time when you see a red balloon, don't just pass it by. Spare a thought for each one of us who bravely stand up and face this giant every day. But for now, I will dream of running, kicking a ball and play. Tomorrow again, I will fight once more because I am going to do life my way. Thank you so much, everyone, and thank you for your time. Thank you for sacrificing family time and for being here this morning. And I just want to say what stands between you and your lunch will probably be the questions and the recommendations and the suggestions. But please do ask, you are more than welcome. And if you would like to contact me, there are my contact details. I'll be happy to communicate with you or share any additional articles or anything else you might require. And there are just a few clinical practice guidelines. If you are interested to go and read up, there is at least quite a few recommendations that have already been published, and I will also happily share some of our research that we've done in South Africa if you are interested. Thank you. That's me.
Thank you very much. All my questions have been answered. I'll go back to parents and let them know.
Oh, thank you. That's great.
And then there was just one comment from Giselle, and she said she would just like to speak a couple of words.
Okay, thank
Giselle?
you. Please go ahead. Let's see if I can wave at you.
We have a moment to remember everything I wanted to talk about. I've tried to do a genetic, well, I haven't tried yet. I've done a lot of tests a few years ago with my neurologist in Pretoria. I don't quite know yet what type of muscular dystrophy I have, but I've noticed that there's a few of the people on this discussion that have a diagnosis. So I'd just like to know from the people and from you if there's anything that you guys maybe can think of, because when it comes to me, the more I use my body, the specific muscles, or the more I walk, or if I use my arms more, the weaker that specific muscle gets. So I need to do normal things, but don't overdo myself, if that makes sense. And I've tried searching something that's similar to that, but I haven't found anything that's fitting the exact one.
Okay, thank you, Giselle. I think that's a very relevant question, and I'm going to open the floor to all the other experts here. I think from my side, I can just say that again, I think it's that balance between trying to maintain mobility, but then also to not overexert. So if you know that a certain activity or a number of repetitions might cause pain or discomfort or weakness for you, then to maybe see if you can do a little bit less. So I think it's trying to find that ultimate balance, but it's really difficult. It's not easy to do. But I'm sure, as I say, everybody else here will have more experience and probably a few more creative ideas. So I'm going to ask everyone to please add your voice. I don't know if you've got any suggestions for Giselle as well, what you found in your own experience.
You know, it's really listen to your body. Don't do too much. Don't exercise so much that the next day you must rest. So I would say listen to your body and ask professional help. Don't try and do everything by yourself. You could do by yourself, could do more damage than good, actually. So ask for help.
Good one, thank you.
No problem. Thank you very much for that.
Pleasure. And Giselle, I think there are quite a number of support groups. We've got different groups, Duchenne and SMA, limb-girdle muscular dystrophy. But because you don't have a label as yet, I'm sure Gerda can maybe just allocate you to one of the groups, because they will also share. I mean, all the members in that group will provide some support and some information, and we share if we've got questions, and all of us will answer. So I think that's also something that's been started recently, which has really been helpful for many of the members.
Just another thing, do you have a clinical diagnosis that your neurologist say maybe he thinks it's a particular type? Or is there...
No, my neurologist just said it's a type of... He said that he can see that my shoulders are being affected. But otherwise, he doesn't say anything else. He just needs me to do a genetic test. And unfortunately, I don't have the funds to afford it.
Okay, Giselle, I think drop me an email. I'm sorry for the noise. My neighbor started working, so it's very noisy now. But Giselle, drop me an email. Let's see if we can get you to a neurologist that can give you a clinical diagnosis. And then for some of the types of muscular dystrophy, we have received funding to do genetic testing. So if you fall in one of those types, then we can do a genetic confirmation for you as well. But please drop me an email.
Okay, no problem. Thank you very much.
Thank you, Giselle. Thank you, Gerda. Any other questions or comments? Okay, so Raj, hopefully you said you've been answered. Thank you for coming with questions. I really appreciate that.
Thank you.
Welcome.
Okay, so I think all that's left over is to thank you. You, Anri, I think you gave us a lot to think about. You know, that it's more than just struggling to breathe. There's other things you need to look at as well. And we really want to thank you also for offering your time on a Saturday morning to come and speak to us. And we'll definitely push on your button again, because I really do think that is such an important aspect of muscular dystrophy that doesn't get enough attention. And thank you so much for fighting the fight with us.
Thank you, Anri. We appreciate it.
Thank you, Sarah, and thank you, Gerda, and for organizing this and for everybody joining today. It's an absolute privilege and honor. And as I say, I salute all of you. Hats off. And yeah, as I say, let's move forwards together. And I do agree, because unfortunately, cardiorespiratory function in NMD has been neglected. And but we are going to change that, each and every one of us. So thank you so much for your time. Thank you for being here with me. And I hope to see you again soon.